welcome everybody. My name is Dustin Jacqmin. I'm a medical physicist at the University of Wisconsin-Madison, and I'm delighted to be joining you today as moderator for the physics plan review for pelvic radiotherapy session. Thank you all so much for joining us on this beautiful summer Saturday morning. I hope wherever you are, you have beautiful weather, sunshine, and that once the session's over, you get to enjoy a beautiful day. I am delighted to introduce our presenter for today. This is Kirk. Maura is a medical physicist at Jefferson Health in Philadelphia, Pennsylvania, where she is the treatment planning lead for a network of hospital sites. She is also a member of the AAPM working group on treatment planning. And she'll be teaching us today about physics plan review for pelvic radiotherapy. So Maura, take it away.
Thanks, Dustin. Thank you all for being here this morning, and I'm excited to present to you our physics plan review for pelvic radiotherapy. So today we'll cover plan quality review for external beam treatment plans for the non-prostate indications, gynecological cancers, rectal cancers, and anal cancers. You're likely familiar with our outline by now, so we'll be going through patient assessment intent, simulation, treatment planning, communication, and DBH, all in terms of what we look for in plan quality for pelvis treatment. So for our patient assessments, we're kind of looking at a framework for how we're going to view the case and how we're going to evaluate plan quality. When we look at the MD intent and prescription, for pelvic treatments, a lot of times we're treating the nodes and we want to review the prescription to see, is it a simultaneous integrated boost or sequential boost? And it's really helpful to have systematic and consistent communication of those things to avoid confusion. So here I just have an example prescription, what we would use for a simultaneous integrated boost, clearly showing that each dose level is being treated for 27 fractions. The special considerations that are common in the pelvis are pelvis. In the pelvis, we're looking at prosthetic metal hip implants that we need to appropriately account for during planning. And there may be some shallow nodal involvement, which may benefit from special consideration of bolus or flash. For prior radiation in the pelvis, this may include LDR or previous HDR treatments where you have to think about biological equivalent doses. And for any previous radiation, you want to attain the most detailed information possible to try to make a plan sum and make educated decisions about the cumulative dose for the patient. Okay, so in our first Zoom poll, I'm going to ask what special consideration is not indicated. So here we just have a short clinical description that you might receive from a physician. Mrs. X is a 52-year-old woman. She was recently diagnosed with anal carcinoma. An exam demonstrated a 5 cm raised lesion arising from the left side of the anal verge on the perianal skin, deeply involving the external anal sphincter. The biopsy is consistent with grade 2 squamous cell carcinoma, P16 positive. The PET-CT scan demonstrated a hypermetabolic right inguinal node. Her history is significant for having kidney failure as a teen. She underwent kidney transplant, and her transplanted kidney is in her left pelvis. So after reading this short clinical description, which one thing do we not need to look for in our quality review?
All right, I've launched the Zoom poll. I see we already have several participants who answered the question. I know there's a lot of details in this one, so take your time and read it through again and consider the options carefully. All right, about 50% of participants have answered. I think we'll give everyone about 30 seconds more to consider this question. All right, so I'm going to close the poll, and you all should be able to see the results. Maura, we had a pretty big mixture of answers here.
Yeah, and I think that's indicative of, there's a lot of information here. So before we even open a treatment plan, there's a lot of little things we can pick up from just a short clinical description that will affect what goes into the plan. So in this case, the one thing that was not mentioned was prior radiation doses. So that was answer 2. All right, so now we'll talk a little bit about simulation for the pelvis. So optimal pelvic positioning is really going to depend on exactly which nodal stations are we treating. Do we need bowel sparing techniques? Are there shallow targets that require bolus? Do we need to consider how to best spare the genitalia? And we're always looking to make the patient comfortable so that the treatment position will be reproducible. So frog-legged positioning is one position that's recommended for anal and perineal malignancy, as it can reduce skin folds in the groin and spare upper thigh skin. That's pictured in the treatment position below. The patient's arms may need to be above their head if periaortic nodes are included in the target. In this image of a patient in the frog-leg position, you can see the patient's hands are high on their chest, but their elbow may still come into the path of the beam if you're treating nodes that are higher up, like the periaortic nodes. So it could be better to have the patient's arms up above their head. And then, as we mentioned, bolus may be necessary if you have superficial targets. So one big consideration for pelvic patients is whether to treat them in the prone position or supine position. And often in the prone position, we're treating them on a belly board. So the plus and minuses of prone and supine position include prone positioning can reduce the overlap between your target volumes and the bowel. For some, not all patients, prone positioning with a belly board provides superior bowel dose sparing to prone positioning without a belly board. Prone positioning can also result in greater setup error, necessitating more frequent imaging. So you want to consider what imaging you'll be doing and also consider your PTV margins if you're using the prone position. Supine positioning is often preferred if you're treating the inguinal nodes, just because they're so close to the belly board and you may have some setup issues there. And then for some more detailed sources and recommendations, we have the radiation therapy for rectal cancer from Astro and the ECOG guideline for contouring and treatment for anal cancer. And actually, the overall recommendation from the rectal cancer group was that prone positioning with a belly board can help to reduce bowel dose. And the overall recommendation from the ECOG guideline for anal cancer was that supine positioning can be better. So those are great resources that weigh kind of the pros and cons of those positions. And then there's some pictured examples here from the ECOG group. They show this butterfly position they're actually using a wing board to position the legs. And then there's some examples of bolus use in the supine and prone positions. And here's an image example. Here's a patient with GYN cancer who was simulated in the supine position. And you can see the bowel is kind of tight to the target. This is a very long target, so a lot of the bowel is very close to our target volume and in the field. And so the patient was re-simulated prone with a belly board to see if bowel sparing could be improved. And you see that the bowel does fall away, or there's some more distance, at least along midline where the target is. But in this case, patient's bladder was more full in the supine position, so you can see it kind of pushed some of the bowel up and away from the lower pelvic volume, whereas in the prone positioning, the bladder was empty and there's more bowel falling close to the field lower down. So these are all considerations that go into the optimal positioning for the patient, depending on their pelvic target volumes and anatomy. For image quality, what we're looking for in the pelvis in terms of CT scan artifacts, a lot of times we'll see significant artifacts from hip implants when there's metal in the pelvis. So you need to evaluate whether metal artifact reduction, or if you have metal artifact reduction, if that could improve image quality. In the image at the bottom of this slide, you can see bilateral hip implants, which kind of obscure the image in the area of your target volume. And with the metal artifact reduction, you get a clearer view of the anatomy in order to contour target volumes and to get a more accurate dose calculation. You want to make sure that your scan range covers the targets in OAR with a sufficient distance to account for scatter. This can be an issue in the pelvis because sometimes at the beginning of your treatment planning or at the time of simulation, you may not know the extent of the superior nodes that will be involved in treatment planning. So it's important for that to be communicated to the simulation team to make sure you have a long enough scan to cover all of that anatomy. And finally, you want to verify that the field of view encompasses the entire patient surface, which can be an issue for larger patients. Here's a clinical example regarding image quality. We have a PTV that extends pretty high, and it's only 1 cm from the edge of the field border. Generally, we want at least 5 cm of image information beyond the top of the target there to properly account for scatter in the dose calculation. So one improvement you can make is to copy the top slice and extend your image. Here you can see the extended image, and that doesn't give you accurate anatomic information, but it does give you a better estimate of the scatter in that area. Variable anatomy is a big issue in the pelvis because we have variable filling of the bladder, the rectum, the bowel. So there's a lot that goes into our considerations of variable anatomy in the pelvis. Increased bladder filling can be used to reduce bowel and bladder dose, but too much filling may not be reproducible. So what we're looking for is a reproducibly full bladder, which can be difficult to achieve, but it helps to give the patient instructions. So instructions on the volume of water to drink and the timing before treatment can be helpful. Giving the patient that information written down, maybe at simulation and when they start treatment, can also be helpful to emphasize why the bladder filling is important and how we want to best reproducibly fill the bladder is great to communicate. An empty bladder can provide more stable bladder positioning, which is most useful if you're treating the bladder. That can help you to use smaller PTV margins because an empty bladder is much more reproducible. You may take scans with a full and empty bladder to create an ITV. So that ITV would give you an estimate of how anatomy in the pelvis is moving when the patient's bladder is full versus empty. If you see excessive bowel or rectal gas, it likely is not reproducible, and this can necessitate larger PTV margins or a resimulation depending on the extent with better bowel preparation. And I have a recommendation here from the consensus recommendations for radiation therapy contouring and treatment of vulvar carcinoma. They recommend a repeat simulation with better bowel prep if the rectum is distended greater than 3.5 cm in diameter.
A question in the chat, and I honestly don't know the answer to it. So Islam has asked, when you want to extend a CT data set to add duplicate slices at the top or the bottom, he asked, how do you do this in the Monaco treatment planning system? And, I don't use Monaco. I don't believe you use Monaco. But I think it's a good general question, which is what kind of tools are out there that can allow you to do this? And, can most treatment planning systems do this, or do you have to use a specialized tool to extend a CT scan?
Yeah, that's a great question. I do not know the answer specifically for Monaco, and I wonder if there's like general image editing software freely available that could do something like that. I'm not sure of the answer to that.
Yeah, me neither. We use MIM to do it, and MIM has like a special workflow you can use. But I think this is a good question for us to bring back to our team and see how do different departments do this, and if there are any sort of general tools that are out there to allow this to be done easily by any clinic. So I'll feed that back to our team, and we'll get back to you on that. We'll make sure that we have an answer available to all of you in Emily's regular email updates. So thanks for that question.
Yeah, thanks. Okay. So for contrast and implanted devices, we talked a little bit about implants in the pelvis. So you want to identify any metal implants with a density that's higher than the maximum value in the CT to density table. Determine if you need a density override. And then in the pelvis, this may include oral contrast, or in the bowel, or contrast in the bladder. And here you can see in this image, the patient has contrast in their bowel to better delineate the small bowel. For implanted electronic devices, in the pelvis, the pacemaker and ICDs will be very distant, but as James emphasized in the last talk, you still want to avoid high energy beams, which may produce neutrons that affect the pacemaker and ICDs. Another thing you may have to deal with in the pelvis are neurostimulators, which may be present in the lower spine and affect treatment planning. I have a little description of what the neurostimulation device does. They're similar to CIEDs. They have a pulse generator component that can be damaged by radiation, and this group recommends a general limit of 500 centigrade to the device. For image transfer, if you're acquiring multiple CT images, such as with a full and empty bladder scan, you want to make sure the planning image set agrees with the patient bladder filling instructions for treatment. So if the patient has been told to fill their bladder, you want to make sure you planned on the full bladder and that the full bladder scan is used for aligning the patient. Here's a clinical example. The patient was planned based on a full bladder scan. You can see up here a reference image of the target volume and the full bladder. And then on treatment, a CBCT shows that the GTV is on the edge of the field due to the target moving because of insufficient bladder filling and an overfull rectum. So this is something you can look out for with on-treatment CBCTs, and you may want to either extend your PTV volume here or make sure the patient is familiar with the correct instructions based on how they were planned. So here's our second Zoom poll. A supine patient is simulated with a full bladder and an empty bladder to create a vaginal ITV. The patient is planned on the full bladder scan to achieve lower plan dose to the bladder and bowel. What is important to verify for treatment?
The poll question has been launched, and I see we already have several participants who have registered their answers. So take your time, consider the options that are there, and select the one that you think is the best answer. All right, a little more than 50% of participants have answered the poll question. So we'll wait another 30 seconds or so, and then we will unveil the answer. All right, seems like we have a nice stable number, so I'm going to end the poll and share the results. We can see that option 4 was the most popular, Maura.
Great. Yeah. So, if you have your patient fill their bladder for SIM, you create a really beautiful plan with a super full bladder. It's just important that the patient has instructions and that remembers in the interim time between simulation and treatment that they need to fill their bladder on treatment so that our calculated plan is as close as possible to what's delivered to the patient. And I guess I'll pause here, Dustin, for any questions so far.
Not many questions in the chat so far. I did want to ask one thing about, bladder filling for my own benefit and curiosity, which is I think, every clinic I've ever worked in has struggled with bladder filling. I think it's one of the most difficult things in radiation therapy because, our patients don't necessarily know how full their bladder is or how quickly it's filling, and every patient is different. How do your radiation therapists adjust to, you get patient there the first day, things aren't quite right. Do you have a good process for iterating, working with the patient to figure out how to, change the instructions to get exactly what you need? How does your clinic handle that?
So yeah, I think this comes up very frequently, even with really particular instructions. It's difficult to get a reproducibly full bladder. So if the patient comes on their first day and their bladder is not quite full, the therapist would probably give the patient, again, written instructions, and also at their next OTV, speak with their physician to emphasize the purpose and the reason for bladder filling.
Yeah, that education component is so important. And sometimes, when the patient is speaking directly to the doctor at their on-treatment visit, sometimes the doctor is able to carry a little bit more weight than the rest of the team. And so it's important to have that messaging coming from everybody, including the therapist and the doctors and everyone who's seeing the patient.
Yeah, and I will say sometimes the patients, maybe if they have experience from the OB/GYN where bladder filling kind of helps the therapist to see more easily, sometimes they think the bladder filling is only necessary to help the therapist to see. So it's good to remind them it's actually for dose sparing and to improve toxicity. All right, now we'll get into the meat of treatment planning. So registration accuracy, as I mentioned, we may have some full empty and full bladder scans that are acquired during their CT session. If those images are acquired within the session without closing out the patient and starting a new image session, they may be by default get linked together in the planning system, but actually the patient's positioning may be a little bit different because they got off the table to use the restroom and came back. So you may need to break that link in your system to accurately register those two images, especially if you're using those for target definition. You may have MRI or PET-CT images to help identify gross disease or nodal involvement. When you're performing the registration or checking the registration for these images, you want to consider bony alignment if you're using it for nodal targets. For evaluation of prior radiation therapy, the focus of your registration is going to depend on your goals for the dosimetric evaluation. So you might need multiple registrations to look at different components of the plan sum. One might be focused on the left hip, for example, to determine cumulative dose to the femoral head, and you may need a second registration focused on a soft tissue target to evaluate the biological equivalent dose to the target volume. Now we'll get into contouring. For ITV accuracy, in the pelvis, we want to ensure that the tumor will be covered with varying volume of bladder filling, rectal filling, bowel gas, and those types of things. So anatomical variation, it causes motion of the vagina, parametria, and other pelvic tissues. And you can create an ITV to get an estimate of that motion by combining target volumes that are delineated on a scan where the patient's bladder is full and a scan after the patient voids. And this can give you an estimate of how those tissues will move. If you have significant rectal filling, you might want to consider including the anterior portion of the rectum in your ITV, because if you have a very full rectum and then it empties, some of those GYN tissues may fall posteriorly due to the emptying of the rectum. And here's a little video you can probably see best on the sagittal view of the movement of those tissues. And so there's a contour when the bladder is full and a contour where the bladder is empty. So you might combine those and fill in the area in between to create an ITV. And then there's a really great description in the NRG Oncology RTOG consensus guidelines in this reference here that you can read about to get a better idea of these things. For target and OAR accuracy, in the pelvis, the targets may include primary and nodal volumes. The OARs would include the rectum, bladder, large bowel, small bowel, kidneys, femoral heads, bone marrow. It may include internal reproductive organs and external genitalia. And there's a lot of really great pelvic contouring resources. So I've listed here some atlases and some specific recommendations based on the disease site. When you're evaluating plan quality, you want to identify any missing targets or OARs and any contouring issues that may affect your optimization or estimate of doses. So again, we're looking for the rectum, bladder, the bowel, kidneys, femoral heads. In GYN cases specifically, we usually contour bone marrow. So in those cases, there's hematologic toxicity associated with the volume of pelvic bone marrow irradiated. And as a surrogate for the bone marrow, we'll contour bony anatomy of the pelvis, and it's recommended to contour about 2 cm above the superior border of the target down to the ischial tuberosities. And here's an example of that contour below. Another thing specific to the pelvis, the internal reproductive organs, such as the ovaries, they can be pretty difficult to identify without an MRI. Occasionally, they're surgically moved from the treatment field, and in that case, the surgeons will usually leave clips to help identify the position. Here's an image from one of the contouring atlases with the contours of several experts, which you can see vary a little bit. It's pretty difficult to just delineate the OARs within a CT scan. We're also contouring the external genitalia in certain cases. And this contour can be used to reduce dose and toxicities such as pain, fibrosis, skin desquamation, and sexual dysfunction. Here's some examples, both female, male, prone, supine, of external genitalia contours here. And that's going to be used to push doses away from that anterior side of the patient, where even low doses can cause excess toxicity. Here's some isodose lines just curving back around that contour, which was used in the optimization. For contour margins in the pelvis, you may have different margins for nodes versus primary target, your primary target due to the internal motion. A common margin for the nodes will be 5 to 7 millimeters, especially if you're aligning to the bony anatomy. And then margins for the primary may be larger to account for those variations in bladder, rectal, bowel filling. Here's a clinical contouring example. we have a contour, a CTV contour extending outside of our PTV. So the problem is that the physician expanded the PTV using a margin from the nodal CTV, but then later extended the nodal CTV to cover more superior nodes. And the planner optimized the plan based on that original PTV. It's common that we use our PTVs for optimization, and it was not noticed that the CTV is sticking outside of the PTV. So the improvement in this case would be to repeat the PTV expansion after all edits of the CTV have been made, and then re-optimize the plan to cover that corrected PTV. For external contour and support structures, we want to confirm that all of the anatomy is included within the body contour, and confirm all objects that would attenuate the beam are included in the body contour as well. We determine if any structure should be blocked during planning, and if an extended field of view CTV scan is needed, and if that's needed in order to cover the entire body surface of a larger patient. You also want to look for image artifacts and degradation on the outside of the patient. You may need to contour and override those areas with the average HU of the underlying tissue. Here's a clinical example in contouring. We see in the image above, the support structure is not included within the body structure for dose calculation, and then the planning system will not consider attenuation through that device if it's not included within the body contour. So the improvement would be to include that device within the body contour and to ensure that all support structures are accounted for in the dose calculation. For density overrides in the pelvis, we override the HU of the oral contrast to the HU of the underlying tissue. And for metal implants, if you cannot use a metal artifact reduction algorithm, you may have to contour and estimate areas of soft tissue in the scan in this artifacted region and override that with the HU of the underlying tissue. You may have to make a separate contour for the bone. And again, we want to identify the metal as accurately as we can. Here's another example from contouring. The problem is that oral contrast causes higher HU in the bowel, which will affect the dose calculation, but will not be present during treatment. So the improvement is to contour the area affected by the contrast and override to the HU of the underlying tissue for dose calculation accuracy. So for flash, when we have really superficial targets, we want to consider if bolus should be used and what else we need to think about in our planning. So bolus can be used to cover the primary volume for vulvar and anal cases that extend to the skin. Bolus over the groin nodes can also be necessary if there's skin involvement or if those groin nodes are very, very shallow. And bolus or flash can help to achieve coverage of the PTV with an expansion. And we want to optimize our fluence to allow for both variations of positioning and swelling. So here's the contour of a GTV from these consensus recommendations for contouring of vulvar cancer. So you can see that the contour for just the GTV comes up to the skin surface. There may also be swelling, and it's not the most reproducibly positioned portion of anatomy. So we want to make sure we account for all of that. Bolus can be applied at simulation or during planning. You just want to ensure that the bolus from simulation is contained within your external contour and accounted for in planning, and make sure everything is communicated in a consistent way. You can also think about skin flash for these cases, similar to what was described in breast planning, where you create kind of a virtual bolus in order to get coverage of a flash area to account for that swelling and positional differences. And then in your final dose calculation, you would remove the virtual bolus. And there's also some treatment planning systems that allow for robust optimization techniques. So that would be kind of considering if your ISO center shifted in different directions, making sure that you have coverage of your target for those shifts. And I have some references here that describe both of those techniques. Okay, so here's a clinical example where a patient has a wet towel placed over their target for a palliative vulvar patient with the purpose of bolusing the target. The problem, which you can see up here, the body contour does not include all or consistently include all of that wet towel. And that was because the HU for the lower threshold on the external structure was set to a default value of -350, which was not low enough to encompass the whole bolus. So the improvement there would be to lower the threshold to make sure that the whole bolus that was used during simulation with the intention of using for treatment is included in the dose calculation. Okay, here's another Zoom poll. Which contouring issue would not have a significant negative impact on plan quality?
All right, I've launched the poll. All right, I've got about 40% of people have answered so far, so we'll give folks another 30 seconds or so. All right, we have about 50% of the answers here. It looks like that number is pretty stable, so I'm going to end the poll and show the results. And we have a pretty even distribution of results here.
Yeah, I think maybe that my use of a negative here is confusing. So 3 of these things have a significant impact on plan quality. So a CTV extending outside of the PTV does have a significant impact. Contrast in the small bowel that does not have an HU override, that would also have a significant impact. And external genitalia that's not contoured can also have a significant impact on the plan quality. If you have a stray pixel of an OAR within a similar OAR, that probably does not have as big of an impact on plan quality. Before we get into beam settings, were there any additional questions on what we've gone over?
Yeah, we have, I think, a really good question in the chat here from Ahmed. And Ahmed, I'm going to rephrase it. Let me know if I rephrase it incorrectly. Ahmed asked, what are the disadvantages of virtual bolus versus actual bolus, and why not use virtual bolus all the time? I think what he's asking is, you have the option of adding bolus at simulation and having it be part of the plan, the image set, which you include in the external and calculate dose on. Or you can add bolus virtually during the planning process and then, create that bolus at treatment and use it there, but not include it in the simulation scan. So, what are the, I guess, advantages and disadvantages of each approach in the planning process and the delivery process?
Okay, sure. I think that if you know that you are going to need bolus at the time of simulation, it kind of gives you a more accurate estimate of how the placement of the bolus will look. You can take pictures of the bolus placed on the patient in the position that it's used for the treatment planning to then relay to the treatment team. So you can kind of get a consistent and reproducible bolus placement based on what you've calculated. And I guess the disadvantage of using it as sim is that sometimes you don't know the full extent and where exactly you're going to need the bolus. So you can create it virtually during your planning, but then it's really important that you communicate, especially in VMAT cases and stuff like that, the size and shape of the bolus. And then it's up to the treatment team to really make sure you can get that bolus kind of flush with the skin, avoiding air gaps and things that may be different between the way that you've calculated your virtual bolus and the way that the bolus is laying for the actual treatments. I don't know if you have anything to add, Dustin.
No, that was a really great summary. I think it's particularly, the point about the extent of the target volume is particularly important. I think generally placing bolus at simulation, there's a lot of benefits to it, but the one big drawback is that sometimes you underestimate the extent of disease that you want to cover near the surface, and you need to have a plan in place for that. The only other thing I'll add is that a lot of new linear accelerators come with surface imaging, and bolus placed at sim. I won't go into the details, but it can be a little bit trickier to use surface imaging when you've placed bolus at simulation and you have to modify your setup strategies with surface imaging. But that's more of a minor concern. Generally the decision to use bolus is primarily driven to ensure target coverage, and that should come first. If there are any issues with the setup process related to surface imaging, you figure out how to do that in your clinic. But I think I agree with Maura. Generally, the benefits of using bolus at sim and having a realistic arrangement of it in your treatment plan outweighs the benefit or outweighs the drawbacks of placing it at simulation.
Yeah, that's a great point about the surface. And the other thing I'll say is, like, in those anal cancer examples where the patient was simulated with a bolus, if you're trying to kind of fill a cavity, if that's your purpose, you might sim with that cavity filling bolus, but then have like a larger bolus that's added virtually and used in treatment as well. Any other questions?
Not at the moment, but yeah, if you have any questions, please put them in the chat and I'll be sure to refer them to Maura during the presentation.
Okay, great. So on to beam settings. With our treatment technique in the pelvis, sometimes we'll use 3D conformal planning for rectal cancer or treatment of palliative disease for non-complicated pelvic target geometries. For GYN and anal cancer, where the geometry gets pretty complicated and you have numerous nodal volumes and multiple dose levels, we generally use IMRT or VMAT to achieve conformal plans and differential doses. For the beam arrangement, for most cases in the pelvis, we're going to kind of have a centered isocenter to improve clearance. For 3D conformal plans, especially for the rectum, what's typical is a 3-field arrangement with laterals and a posterior beam, and you may see a 4-field beam arrangement with a PPA and laterals. The 3D field arrangement can be most useful when you're trying to spare bowel anterior. For VMAT, 2 to 3 arcs that may be either full or partial arcs are typical. The arcs may be truncated posteriorly to protect the rectum or anteriorly when the patient is in the prone position to protect the bowel. Here, there's an example of a somewhat regular volume. It's pretty close to round, and maybe 2 arcs is fine for that. When you have more complicated volume, you may end up needing 3 arcs and rotating your collimator to help with central blocking. In terms of beam arrangement, one thing to consider in the pelvis is whether or not you want to allow beam entry through metal implants. So generally you want to avoid if you can. And so here's an example of a 3D rectal plan where the beam's just been rotated a little bit obliquely posteriorly to avoid passing through this metal hip implant. In cases with IMRT or VMAT, you may want to contour the metal implant and then give it a margin that's greater than or equal to the expected setup deviation in that area, and then avoid allowing your beam entry through that volume. So the margin from the metal implant that you want to use is going to depend on how confident you are in the positioning of that metal implant throughout the course of treatment. So if it's closer to the PTV, the margin that you use will probably be similar to the PTV margin. And then if it's further from the PTV, such as in this case in the femoral head, you may have some rotation, you may have more displacement, so you may need a larger margin to prevent the beam entering through. For beam deliverability in the pelvis, our beams are usually coplanar in the pelvis, so the main risk of collision would be between the gantry and the couch when the patient is kind of high up on a prone belly board and their isocenter is posterior within their body. It's pretty high off of the table. You want to screen for potential collision in whatever way that you have available to you. There are some fancy commercial collision check software, or if you just have a rough idea of the distance between isocenter and your linac head to know when it's something that you need to look out for, you can just take that measurement. So one thing you can do if there's a potential collision is to shift the isocenter anteriorly or avoid beam angles with a potential collision. So here's a clinical example of that. This patient is prone on a belly board, so they're pretty high up off the table. And then in addition, their isocenter is posterior within the patient, which is even higher from the table. So the anterior angles may cause a potential collision with the table. So you can either truncate your arcs and not use those anterior angles, or if those anterior angles would be helpful to get a better dose distribution, you would shift your isocenter anteriorly to allow more distance for clearance of the gantry head around the table. For beam robustness in the pelvis with our variable anatomy, you may have some mobile soft tissue in larger patients, and then you have your variable bladder and bowel filling. So those are the main considerations when thinking about beam robustness, trying to avoid beams that go through variable anatomy when possible. For our beam energy and dose rate in the pelvis, a lot of our targets are deep and high energy is beneficial for that. But if you have a shallow component of your target that comes close to the surface of the patient, lower energy may be better in order to achieve coverage of those shallow areas. And sometimes your targets are a combination of shallow target and deep target, and you may end up using a lower energy just to cover those shallow components. You want to verify the dose rate is appropriate, and for the pelvis, generally, we're using the highest dose rate available. For collimator angles, you want to confirm that your jaws conform to the target, that the MLC can close between targets, and that the angles you're selecting allow for the best dose shaping possible around the OARs. For VMAT in general, we avoid a collimator of 0 degrees, and we vary the collimator among arcs. So in the pelvis, for some pelvic sites, you have wide, complicated targets, and this can cause the MLCs to reach their over travel limits, and then they get left open outside of the target volumes. This may not be obvious in your dose distribution unless you directly play your leaf motion in the beam's eye view. So you want to set your collimator and jaw limits so that all of the target can be seen in at least one beam, but maybe not all beams, and then limit your field width to prevent these over travel issues. In the example below, there's an arc with a collimator close to 90 degrees, and that can help to kind of block this medial area between nodes. You want to review that the beam's eye view for appropriate target coverage and excessively small apertures, and then, as I mentioned, screen for MLCs that do not conform to the target due to over travel limits. So here's a clinical example of how that can manifest. So the patient has a geometrically complicated pelvic target. We have some SIB doses going on with the nodes prescribed to 47.6 gray and an SIB boost to 60.2 gray to the primary. The beam extras were set to 18 cm, and we can see when first opening the plan, I notice here there's kind of a hot spot of 57 gray posterior to the boundary of the target, and the target in this area in the nodal volume was prescribed only to 47.6 gray. So that's a pretty high hot spot. It's located outside of the target volume. And then when I played the leaves in the beam's eye view, what I could see here with these beams lined up right here is that they're all trying to close to the target, but they're stopped at their over travel limit, leaving this open area, sending dose through to the patient, where the leaves really should be closed to prevent this hot spot. I should go back. In addition, I just wanted to point out here, in this case, the bone marrow was contoured, but what was recommended in the earlier slide is to contour your pelvic bone marrow about 2 cm above your target, because you could see that this hotspot occurs right outside of where the bone marrow is contoured. So constraining that area through the bone marrow contour may have prevented that hotspot as well. So in this case, the improvements that you can make are to correct the bone marrow contour, to cover the bony anatomy to the extent of the PTV and 2 cm beyond, to reduce the field width so that the MLCs are able to close where they need to close and only be open in the area of the target. So it's so helpful to play the leaves of the arc with the PTV on to see if you're encountering this issue, and ensure that the MLCs are conforming as you play that. So in the improved plan, we're able to reduce that hotspot. For the modulation factor, it's going to be related to the complexity of the geometry. And for yep. Oh. Please mute if you can, unless you have a question. Do you have a question? So the modulation factor is going to be related to the geometry of the target. So with rectal cases where you have a more simple geometry, you may have a modulation factor closer to 2 or 3. But as you get more complex geometries, such as with anal and vulvar cancer, you may have modulation factors closer to 4 or 5, or maybe up to 6. In terms of beam modifiers, a frequent place in the pelvis that we see beam modifiers are using wedged beams when we use that 3-field 3D technique. So this technique, you usually have an open posterior beam, and then your lateral beams are wedged with the heel posterior to account for the attenuation of the posterior beam. For bolus, you want to verify that bolus is appropriately used for superficial targets and confirm necessary parameters, including the bolus size, thickness, density, and attachment to treatment fields. So we mentioned the various cases in the pelvis where you might use pelvis, and I just want to emphasize the important thing is anything that's used either in simulation or during treatment planning, make sure that it's accounted for in the calculation and then communicated in a clear way to the treatment team. Okay,
Maura, let's
sure.
before we go to optimization objectives, we do have a question in the chat about how to manage really long targets. So the question is, how many isocenters do you use if there is a big PTV in the longitudinal direction, say greater than 32 centimeters, or as like maybe 40 centimeters, as long as the MLC bank on a typical linear accelerator? Is it possible to use 2 isocenters to cover this large area?
Yes, it could be possible to use multiple isocenters. I think the first goal is usually to contain everything within one isocenter for ease of treatment and delivery. And for example, we have some HDMLCs that have a smaller field size limit. And there are ways with rotating your collimator and optimizing your jaw positions in terms of MLC motion, where you can achieve longer fields than what your field size limit is. But there's always going to be something that's beyond the length that's achievable of your treatment fields. And in that case, you would have to split to 2 isocenters. There are techniques, actually, which I'll discuss in 2 weeks for craniospinal optimization, where using multiple isocenters in the longitudinal direction, you can make kind of a robust optimization of the dose along the match line so that you don't need to feather. That's kind of a more in-depth planning description, but I will go into that in 2 weeks if you're available then. All right, so we'll go into optimization objectives. We want to verify that targets have upper and lower objectives with reasonable separation and upper and lower dose values. So you'll want to separate for SIB cases. You want to create planning structures for each dose level, cropping the lower dose structures out of the higher dose target volumes and give them, again, reasonable separation with lower and upper dose constraints to try to get uniform dose within each of those dose levels. For OAR objectives, you want to check that all of the relevant OARs have upper objectives, that they're, again, contoured, that you separate appropriately overlap regions. You may have to give lower and upper objectives where the target overlaps with and then you might really push the area of the OAR outside of the target. I think James gave some really good examples of that last week. And then verify that the objectives reflect the appropriate prioritization. So in the pelvis, most of the OAR constraints have a lower priority than target coverage, except potentially the max dose to the small bowel. So just make sure with constraints that are difficult to achieve for a particular case that you communicate with the physician on what priorities you should look for. And then you want to investigate the impact of structures not included in the optimization. So keep an eye out for conflicting objectives, and again, make sure things are prioritized in the way that are clinically desirable. So in this case, here's an example, target volume in pink here. The prescription is 45 gray. The bladder volume is 165 cc. The overlap volume between the PTV and bladder is about 50% of the organ. So when we look at what constraints are met and not met, there's a constraint here that the dose D35 is less than 45 gray. However, this is violated by the plan. So considering that 50% of the bladder is within the target volume and the prescription is 45 gray, the physician wants to prioritize target coverage, so it makes sense that this is violated. Something you might want to look for here was a bladder minus PTV volume used for optimization in order to best spare the area of the bladder that is not in the overlap region. For gradient tools, we want to confirm the appropriate use of planning tools and dose shaping structures like rings that are available to you in your planning system. Some examples would be the normal tissue optimization objective, dose fall-off objectives, and rings, which you can create as expansions from your target volume. In the pelvis, the use of rings really has a significant impact on the dose fall-off when you get those complicated targets and involve nodal structures. So here's a clinical example. Again, we have a pelvic target that has a complicated geometry and SIB doses. We have a lower dose to the nodes of 45 gray, and the higher dose to the target volume here medially is 54 gray. So the problem with this plan, this is the 45 gray isodose line. It's not really conformal to the 45 gray target, and we have a lot of normal tissue here in between, which maybe is not constrained and not being spared appropriately. So the prescription doses are not conformal to each of their dose levels. And then additionally, in this case, the external genitalia, which is anteriorly here, was not contoured. So then something that you might suggest to improve the plan would be to use some kind of a ring structure. Here's an example, and this is the NTO settings that were applied. And then you could recommend to contour the external genitalia and apply a constraint. So the improvement for this plan, again, to add the ring structure, to use some NTO settings, and to contour and constrain the external genitalia. On the left here, you can see the original plan, probably not as conformal as it could be. And then by applying those ring structures and constraining dose to our external genitalia here, you can really pull that dose back anteriorly and get the isodose lines to conform to the low dose structure here and spare the area between the low dose and high dose structure. Okay, for dose distribution, the first thing we'll look at is the prescription and normalization. So you want to verify that the plan prescription and normalization methods are appropriate. And something that can come up in the pelvis, you're usually normalizing your plan or optimizing your plan to ensure the prescription coverage of the highest dose level volume. So you just want to make sure any way that you normalize the plan for that highest dose level is still delivering an appropriate amount of dose to the lower dose targets to make sure that in scaling for a higher dose volume, you're not delivering too much or too little dose to the lower dose volumes. Here's a clinical example looking at the dose distribution. So again, as a common theme in the pelvis, we have complicated geometry. A lot of these cases are planned SIB. So there's a low dose to the nodal PTV of 50.4 gray and a high dose of the PTV 70 gray. So in looking at this dose distribution, we can see here there's some prescription dose spilling in between nodal volumes. And then you can see with this area prescribed to 50.4 gray, the 40 gray and 35 gray isodose contours are kind of convex where they should be concave, curving outward instead of curving in towards the structure. And then if you look at the DVHs, there may be a strict coverage requirement on the PTV 70 gray, which ended up scaling up the dose to the lower dose volume. So almost the whole lower dose structure is covered by 52 gray. So that could probably be dropped a little. So the improvement in this case would be maybe to use some tighter upper objectives assigned to the lower dose target. So drop down your coverage objectives on the lower dose target to apply a ring structure, and then to verify, after optimization, that your doses are curving in towards the target and that those intermediate doses are being constrained and kind of separate medially where there's no target volume. For the algorithm and dose grid in the pelvis, we're usually not dealing with super small structures, so a 2 to 3 millimeter dose grid is generally appropriate. In terms of target coverage and conformity, we review that the target dose conformity and coverage looks good for each dose level. For sequential boosts, the conformity and coverage should be examined in each of the individual plans as well as the plan sum once you combine them. And then for SIB, you want to review the conformity of the dose for each dose level. For hotspots, you want to review the magnitude and location of the hotspot and any high dose streaking. For sequential plans, you want to look at the hotspot in each of the individual plans. And for SIB, review the it's good to review the hotspot per slice to look at the magnitude of the hotspots in the lower dose target volumes, which might not be apparent if you just look at the overall hotspot of the plan. In the pelvis, the hotspot for more simple geometries might be somewhere around 107, but once you get into the more complicated geometries, you may see higher hotspots closer to 110%. For dose gradients, review high, medium, and low dose levels and have sort of an expected dose gradient that you're looking for. Evaluate the dose gradients with abutting lower dose targets. Ensure upper limits on lower dose targets are not degrading the target coverage. So if you have a really tight upper objective on your low dose and you don't have an appropriate distance between the low dose and high dose structure, you may actually be pushing down on the coverage of your high dose target. Typical IMRT or VMAT dose gradients, you might see 3 to 5% isotropically around the PTV if there's no OAR present, but when you really push, you can achieve something like 10% per millimeter inside a high priority OAR adjacent to a large PTV. For parallel OARs overlapping the PTV, the 50% isodose line should kind of pinch in and be located somewhere around 1 cm away from the PTV at the closest point. For OAR sparing, your goal is to confirm that all OARs are spared as much as possible. And so you might look at if the target coverage required is that V100 is greater than 95. You want to verify that the target is really only cool in areas of prioritized OAR overlap. So here you can see we have really good target coverage. The V100 is only pinching in right in areas of overlap with the bowel there. So here's some example dose distributions. In the superior image, the rectum does not appear to be optimally spared. We have the 50% isodose line just kind of spreading out isotropically. An improvement might be to kind of push on your rectal doses so that you can see that 50% pinching in a little bit.
Hey, Maura?
Yes.
We have a question in the chat from Aragamo. He or she asks, does a plan with a simultaneous integrated boost give lower doses to organs at risk than a plan with a sequential boost?
I would say not necessarily. I guess in either case, you should be able to achieve similar doses to the OARs. It can oftentimes be easier to achieve the best dose distribution with an SIB because you're just optimizing on a single plan. But I would think your results should be similar. The overall plan result should be similar in terms of dose to OARs. Is that your experience, Dustin?
Yeah, exactly the same experience. It's a little trickier when you have to do sequential boosts because you have to kind of minimize OAR dose in 2 plans and then add them together and see what the composite looks like. And sometimes it just takes a few more rounds of playing with the objectives to get the combination to look the same, but the potential is always there. For our DVH metrics, you're looking to review the DVH metrics and relevant clinical goals in the context of national and institutional normal tissue dosimetric goals. Some resources or references for those dosimetric goals in the pelvis, you have Quantac, there's NCCN guidelines, and then there's some great clinical trials that are published that you can apply their clinical goals for the appropriate cases. And then I just wanted to point out for our physicians, the type of chemotherapy applied for these different disease sites can also affect the constraints. Certain bowel doses may be acceptable if there's no chemotherapy being delivered, but then you might use tighter constraints on bone marrow or other OARs depending on the toxicities of that patient's specific chemotherapy. For composites with prior radiotherapy, we want to make sure that we're accounting for any prior dose that the patient has received.
And you should verify that the composite plan considers biological dose when combining different fractionation schemes, including LDR and HDR cases. The American Brachytherapy Society, and I've provided the link below, they have some great spreadsheets for summing EBRT and HDR doses. And this is our final Zoom poll. If a plan dose does not look conformal, where can you look to figure out suggestions for plan improvement? So you have a plan dose that's not that conformal. You want to give a suggestion to the planner. Where can you look to see if it's optimized in the best way for the current case?
All right, I've launched our final poll. We already have a few answers. Looks like we have around 50% of the attendees have answered. I'll give it another 20 seconds or so. All right, going to end the poll and share the results. It looks like all of the above was the most popular option.
That's great. So if you encounter a plan that does not look particularly conformal, you can look at the optimization objectives to see that OARs were properly constrained, that ring structures or normal tissue objectives were used. You can look at the collimator angle to see if it's ideal and if the MLCs are able to block outside of the target based on the angle selected. You can play the leaves in the beam's eye view to look for issues. And again, check that a ring structure or some kind of normal tissue objective has been used. So all the above was the correct answer. Okay, communication. There are actually a lot of things to communicate with regard to treatment of the pelvis. So we have prone versus supine positioning, the bladder filling instructions, use of bolus at simulation, the communication of any bolus added during planning. You may have to communicate based on the field length in terms of the field length of your target and your treatment field versus the achievable field of view for the CBCT. So if your CBCT field of view is not long enough to cover the entire target, you may want the therapist to focus on the lower portion of the target to check bladder and rectum filling, or there may be a nodal structure that's being boosted higher up that the physician really wants to see. The physician may request multiple CBCTs to cover the full length or alternating lower and upper. Whatever is most important to see for the setup just needs to be communicated to the treatment team to make sure they're taking the correct images. I'm going to communicate any bowel preparation that the patient has been instructed to perform, and then communicate any guidelines to ensure blocking during planning is executed. So I mentioned for a hip implant, you may apply a certain margin and avoid entry of the beam through that margin. So you may want to communicate that to your treatment team and say, ensure the hip implant is completely within that expansion ROI. There also has to be communication from the treatment team back to physics dosimetry and the physicians due to the highly variable internal anatomy. So the bladder and bowel changes can deform and displace the target. I have a little example here of the planning CT with a very full bladder volume. However, on treatment, we see this very full rectum is sticking outside of the PTV. So therapists should be instructed to call the physician, call physics, make a decision for that day, and then going forward and planning anytime there's kind of a large variation of the internal anatomy in an area relevant to the target. Another point of communication back to from the treatment team back to physics dosimetry and the physicians will be large SSD changes. Sometimes these patients, when they're feeling very sick, can rapidly lose weight. So when there's SSD changes greater than 2 to 3 cm, that should be communicated back to the physics team to evaluate tumor changes, weight loss, and how that affects the calculation of what was planned. For incident learning, we want to ensure communications and that everyone learns from any unexpected deviations or learning opportunities. So it's good to have an incident learning system where you can track and reference things that happen and that you can learn from. In the pelvis, again, review imaging for internal variations that exceed assumptions used during planning. If you're seeing large variations outside of the PTV margins that you're assuming, maybe things need to be expanded or setup needs to change. So if you see internal motion greater than the ITV or PTV margins due to changes in rectal and bladder filling or bowel gas, if you see the metal implants are moving outside of the margins used to avoid entry, maybe expand that margin used to avoid entry. If you're seeing consistently low bladder filling than what was planned, this can cause an increase in the dose that you've assumed the bladder and bowel are receiving. So maybe you need to improve the communication of bladder filling or the volume that you're instructing the patients to drink. Okay, and I think that's all I have for the pelvis, and I'm open to any questions. And it's been a pleasure to present to you.
Thank you so much, Maura. Yes, we have time for questions. So if anyone wants to ask a question or put a question in the chat, we would be happy to answer that right now. Maura, we do have a question from a couple of minutes ago. HP asks, how do you calculate and evaluate dosimetric constraints for organs at risk when you're treating a simultaneous integrated boost? For example, you have some traditional fractionation, say 2 gray in times 38 fractions, and now you have a dose fractionation where you're only treating 30 fractions, and so the SIB is being hypofractionated, the total number of fractions is a little bit different. How do you apply the dosimetric constraints to the bladder and the rectum and other organs at risk when the number of fractions has changed?
So that's a difficult question to answer. Some of these disease sites, I believe, have clinical trials that examine that or that included SIB that maybe have constraints that you can use as a reference. Sometimes we just use the constraints from whatever the standard fractionation is and are mindful of the hyperfractionation. Like if things are close to violating that, we might push to reduce those doses further. But yeah, that's a difficult question to answer, I think. I don't know, Dustin, do you have any particular practice?
Yeah, whenever you're, as a physicist, you're reviewing a plan and you see a treatment planning order or a set of directives and dose objectives that, maybe, I guess I'll give an example from our clinic. Our orders are all labeled with the number of fractions that are supposed to be used with that order. And sometimes the fraction count in the physician's plan won't match the number of fractions in the order. And in that case, we always reach out to the physician and say, hey, this doesn't match. Is there another order? Or, Maura gave a great example, clinical trials. Very often, the prescriptions physicians use are driven by clinical trials, and those clinical trials have objectives. So often the first place we go is those trials. And the second place we go is to the physician and say, hey, this doesn't match up. Radiobiologically, things aren't going to be exactly the same. What do you want to do? And we get some direction from the physicians we work with regarding how to apply objectives when the dose fractionation is a little bit different than the intended use. I'm not seeing any other questions. I just wanted to, reiterate something you said in the last couple slides, which is we've talked about the communication plan a lot in these presentations as sort of a one-way communication stream between physics and the therapist and the planning process and the therapist. But you're absolutely right that it's not a line, it's a loop. And a good communication plan will have opportunities for the therapist to feed information back into the planning process, whether it's patient-specific and very short-term or longer-term via incident learning. And so it's really important to establish good communication patterns with your therapist and dosimetrist so that you can actively improve care for your patients. So thank you for highlighting that. I think that's really important.